Vicky from Ontario Health. We will get started in just a minute. It's just 2 o'clock right now, so maybe we'll just give 1 more minute before we get started. In the last minute, this is our webinar to review the Assessment Center template. Thank you very much for joining. I think we still have some names popping on, so we'll just wait. We'll give a few more seconds. The one thing I would please just ask is, given the large number of participants on the call, if I could please ask you to mute your line when you're not speaking, that would be very much appreciated, just so we can limit background noise. Thank you. Okay, well, thanks. Thanks again to all for joining. We'll get started. I see that we still have some people popping in, but just in the spirit of time, we will start off. I will just start by asking everyone to just mute your line. We will have some time for questions towards in a little bit, but in the meantime, if you could just mute, that would be great, just given the number of participants we have. I will just also note that we are recording this call, and that's so we can share with others that weren't able to make it today. So again, wanted to thank you all for joining, and I really want to thank you for your participation in this work. You have received a costing template with a cover note that explained the purpose of this. But just as a quick recap, the purpose of this template is that our team at Ontario Health has been engaged to really work to understand the current state of operational costs to perform testing and assessment for COVID-19. And part of that is really understanding what that current state and what all those operational costs look like in the various models that take place across the province. The intent is that as we collect and collate this information, where it will be used to inform and develop recommendations that will then support the ongoing sustainable future for COVID-19 testing and assessment for as long as it might be needed. I'm going to turn it over in a second to Julia and team to really walk through the survey, and then we'll also open up to your questions. Before we do, the one comment I really want to make is that I do very much appreciate that there is a lot of information that's being asked for in a short time. And I want to just kick things off by offering an apology for that, both in terms of the quantity and the turnaround. The level of detail in the survey really in the template really is important in making sure that we have a good, comprehensive and consistent understanding. And the timeline is driven by providing input into those recommendations that I mentioned to make sure that we can proceed with a strategy and can share that information back in a timely manner. So that's just a little bit of the background. And maybe with that, Julia, I'll turn over to you and team to do the walkthrough of the template. And then I know we'll have some time for Q&A after that.
Thank you, Vicky. I am pretty much passing the mic over to Judith. I just wanted to thank everybody who will be filling it out, everybody who helped us to construct this template, and just so that you could understand a little bit better why the template might not be exactly tailored for your specific scenario and situation. We have been trying to make sure that we have one template that would be general enough to encompass everybody's scenario, because it was simply impossible for us to devise multitude of various templates. And we have had a number of inputs from some of you to help us understand the cost drivers and for each of the model of care. And that's what we've put together as a template for you. So it may not be 100% reflective of your situation. So we'll need to figure out how to make it reflective. But we're hoping that it is general and comprehensive enough for you to be able to give us some meaningful information. So with that, I'm going to pass the mic to Judith, who is our methodologist on the team, who will walk you through the template assumption, organization, and emphasize some points, and then we will take questions. If we can't answer all of them on this call, we will try to get it to you, the information to you after the call in the Q&A document, and we will also be having the same seminar with Q&A tomorrow as well. So thank you so much. Type your question in the chat box if you wouldn't mind. Thank you. Judith, over to you.
Thank you, Julia. So I want to walk us through each tab in this template one by one, and at the end we'll have time for questions. So if you could just stay muted until finish the walkthrough, I'll try to do it as quickly as possible so that there's time at the end for questions. I want to start by echoing what Julia and Vicky have said. In terms of the development of this template, we had to develop it quite quickly. We did it after interviewing several different assessment center sites to get a sense of their operations and their cost drivers. So huge thank you to all the sites that gave time to us to explain their operations. This template hopefully reflects what we heard from those sites. That said, I can pretty much guarantee that this template will not be a good fit for your site, because what we found is there was a tremendous amount of diversity between the sites that we interviewed in terms of their logistics, how they operate, the variety of services they offer.
Good about this costing webinar.
Okay, I'm gonna go tomorrow. I'll talk to you.
Just a reminder to please mute yourself. So there's an incredible amount of diversity across the province in assessment centers, which means that this template probably doesn't look like it quite fits with what your assessment center does. So we do know that, and we really appreciate the time and attention that you will need to spend in order to complete this template. We're very grateful in advance for the work that you're going to be putting into this. We recognize that it will be a lot of work. So that said, the cover page includes some very important information we will need from you, which is your assessment center contact information. We're going to need this for any follow-up questions that we may have after you've filled in the template. And we may well need to follow up with you as sometimes the information can be ambiguous. Also on here is some information about how this costing input will be used that Vicky covered already. I want to emphasize that we have already collected costs associated with lab processing through a separate template. So any information on lab processing should be excluded from these costs. So for example, if lab provides transportation, don't include that here. Swabs or that kind of thing, don't include that here. We've already captured that through a separate template. There's a few important considerations on here as well that I won't go through in detail, but it has some important information about the scope of what we want to collect in this template and how to submit the information. So there is space for additional services, but we want to collect these separately so we can understand the variation across the province in terms of the additional services that are offered. Also note here that the focus of this template is current state operational costs. Please don't include any one-time costs in this template. And then there's some additional options for if the template format does not work well for you. You can submit information separately from the template, but I would just encourage you to, as much as possible, try to submit your information within the template format because we are going to be receiving a lot of templates and our turnaround time is very quick. So we can't guarantee that we'll be able to include your information if it's not provided in the standardized format, just because of our analytical capacity constraints. It also includes a list of all the tabs in the file, and I'm going to go through all of those next. So the first tab that actually has data collection is the administration tab, and this is meant to cover all of your administrative and your support staff. So any directors, managers, also any IT support, decision support, any coordinators should all be on this tab. At the very top, we've included a spot for you to provide free text describing your assessment center model. For example, the geography and population you serve, any key partnerships we should be aware of, or unique features. This is a good place to put in any particular features of your assessment center that you want to highlight as either being challenging or as alternatively working really well. Next, we want to know the number of operating days per week, as that's used further down in some of the other calculations. Important to include here is your personnel, which are your administration and support personnel that are supporting your assessment center across all of your models, be that one or more models. There's a drop-down list of personnel types. Again, I would encourage you as much as possible to use this list so that we can easily compare your data to others. However, if you can't, you can pick other and specify in notes. For each of your personnel types, we're looking for total FTEs, their average hourly rate, including benefits, and the average number of hours worked per day on the assessment center. So if you have, for example, a medical director who spends an average of 4 hours per day on the assessment center, you would put that in as 4 hours so that we can capture that information. There's some additional notes here about how to cover different scenarios in terms of your staffing. So for example, if your hours per day vary, if your staff are working 8 hours on weekdays and 4 on weekends, add up the total, divide by the number of days of operation. If salary rates vary, again, use a weighted average rate so that we capture the rate that applies to across your staff. And finally, if personnel are not paid on the assessment center budget, so this could be physicians who are billing OHIP, fee for service, or if you're getting in-kind support from staff from another partner agency, include them in the list. Leave the hourly rate blank and put in the notes the funding source for those staff. So that could be OHIP, that could be in-kind, that could be the health unit, whatever it is. Also on this tab, there's space for supplies. In this case, we anticipate it would just be office supplies, but there is space for other supplies if you have other supplies, and space to enter overhead costs. In terms of how to calculate overhead costs, there's a few different options. You can note whether the cost unit is per day, per week, or per month, the cost per unit, and then it will calculate a cost per day, which is why the number of days per week is important as it's used in that calculation. And then the percent associated with COVID-19 testing. So you may have a space that is shared or other costs that are shared. So we just want throughout this template to try to isolate as best as possible just the costs associated with the COVID-19 testing. Next is virtual services. So this tab, I would expect everyone to fill out this tab because it includes testing follow-up, which I anticipate would apply to every test center. There are a lot of other services on this tab that may or may not apply to your assessment center model. In all cases, across all tabs, if a particular service doesn't apply to you or doesn't apply to you under that model, you can just leave it blank. At the top of each of these tabs that I'm going through one at a time, it starts with some information on your operating hours and operating days and some information on your general volumes. In all cases, use your last week in order to fill this out and average over your number of days of operation in order to get, in this case, it would be your average calls per day, your max capacity, which may be the same or different from your average, and your percentage of symptomatic cases. Similarly here, we're looking for all of your personnel providing virtual services. And then, unlike the admin tab, as we get into these other tabs, we're starting to also collect information on the specific activities that these staff are doing. So up here, you would select the staff types that are staffing your virtual services center and their total hours per day. And then below, we're looking for the number of minutes per activity. The reason we're collecting both of these pieces of information is that we understand you may have a call center that needs to be staffed for a certain number of hours so that it's available for people to call in, but it may not be operating at the max capacity. So we're collecting the activity information and the hours per day separately.
Judith, give me 1 second. I think I thought that it would be good to cover the questions in the end, but some of them may be more kind of situational. So maybe once you review this tab, maybe we can pause and review the questions that they just came in. How's that?
Sure, absolutely.
And then we'll proceed. Yeah.
Okay. So if we look at the activity table for each of these activities, only complete the row if that activity is done virtually at your assessment center. So if you do virtual patient assessment, screening, and eligibility, fill in this row. If you only do that in person, leave it blank. Select the personnel type who's doing that activity, the average duration per case in minutes, so that may be 5 minutes, that may be 10 minutes. The hourly rate is set to pull the rate from the table above so that you don't have to retype it. However, if for some reason that automation does not work in your case, you can overwrite this cell as well. For this particular tab, we are looking for separate volumes for each of these rows. So how many initial patient assessments your center would do per day. That's not the case across all tabs, but we have found that we believe this may vary quite a bit, so we want the volume for this specifically. A few of these rows are separate for symptomatic patients and asymptomatic patients, so we want separate time estimates, for example, for patient education and counseling, whether it's a symptomatic patient or an asymptomatic patient. If your particular practice is that you spend the same amount of time for both of those patient types, just complete both rows, but use the same time for both. We just wanted to give the option in case the time varies. The same for results reporting. There's 2 rows. Results reporting for symptomatic patients, results reporting for asymptomatic patients. If the time is the same, report it as the same. If it varies, please report it differently. If you are not reporting results to all patients, that is also fine. Only include the volume for which you are reporting to those patients on a case-by-case basis. We've also included a row here for results reporting to public health. We assume this will be done in a batch. So this is estimating the total duration per day rather than individually per case. And in both of these cases, there is space for you to specify other activities that you may be doing that are not listed here. But these are other activities that are related to COVID-19 testing specifically. For other activities that are not specific to COVID-19 testing, we have added another table below because we heard in our interviews that there may be additional services offered through some of these models. So we've included space for virtual consults. So this is, on the phone or through telemedicine with a physician or other health professional. Other remote monitoring services, but please specify in the notes what those might be, or other services, please specify. So these would be activities that may not be directly applicable to COVID-19 testing, but if you are doing these activities out of your assessment center, please list them here. Similarly to administration, we're collecting supplies, which we again assume would be office supplies in this case, and overhead costs. And those should be filled out the same way as you would for the administration tab. And I'm going to pause here. Julia, do you want to let me know if there are questions?
Yes, the first question is, how does this report relate or reconcile to the overall COVID-19 expense reporting template, BCS, I'm not so sure what BCS stands for, and other reporting already taking place? There are redundancies in reporting and duplication of effort. We do appreciate that some of the information may indeed be duplicated. However, the purpose of the expense tracking to the ministry to capture incremental costs, they're netting the costs. So and what we're interested in finding out here, what is your complete direct and indirect operational costs? So to operate the center, given this or that model of care. So the purpose is slightly different, and how you will be reporting that will be slightly different. Using very specific example. If you repurposed, let's say, some of the equipment or staff in the past and had to hire, like, let's say 3 FTEs came from, let's say, another ward, and then you had to hire additional FTE for COVID-19. In expense tracking, you would report just the cost for one additional FTE because that's your net incremental increase. Whereas we would be interested in finding out that you actually have 4 altogether. The same with the pieces of equipment. If they had been repurposed and one additional piece of equipment had been purchased, ministry would have to need to know that cost of that one additional pieces of equipment. We would need to know all of the operational, not one-time cost, but all of the operational maintenance costs. So hopefully that answers the question. Judith, do you want to add anything to that question? Because there are quite a few more.
No, let's keep going.
Okay, what time period does this cover?
So this in general, this template is current state. So use your last week of data when thinking about the hours, the cost per hour, etc. We're not collecting retrospective costing going all the way back in time. We are not collecting one-time costs that you had previously incurred, though I will get to this later, but we have included a space for future costs if there are important differences that you would like to note. But the majority of this template is for current state, and you should use your last week of operations as the reference.
Good. Thank you. Next question. Can you please again explain why you assume virtual service tab will apply to all?
Yes. So the only part that I think should apply to everyone is the reporting. So I expect that even if you're not operating appointment booking or screening virtually, you would be doing your results reporting virtually because it's after the patient has already left. So we're including results reporting to both the patient and to public health in this tab, and assuming that all assessment centers would be doing those activities. If you're not doing those activities, and because we absolutely may be wrong about some of our assumptions, yes, leave it blank. Please put a note so that we know you didn't just miss it.
Thank you. So next comment, the screen is not being shared. We will try to do our best to make a reference to the tables that we speak to in subsequent discussion, but unfortunately we may not be able to do it all the time. We apologize. You may have to get back to the recorded video because it's screen is being shared, so it must be an issue on your end, unfortunately. Sorry about that. Next question, what if there are no additional costs as staffing, rent, supplies are already funded by another means? Are we only calculated uncovered costs?
Yeah, absolutely. That's a great question. So for staffing, as I mentioned, please do include the FTEs and the hours in these tables so that we know what staff you have, even if you're not paying for them. So that's important, so we understand your model of care, and you can leave the cost blank as you're not paying for it. To give us some additional context on that, jumping ahead again, we have a separate section for costs covered by other entities. So if you know what those costs are, even though you're not paying them, you can include that here for us as well.
Thank you.
Yeah, for supplies, I would say, if your supplies are being covered by someone else, just include those again in costs covered by other entities. You can, there's two options. You can also put those in these tables and note that it's covered by someone else.
Next question, virtual services, would that include calling people back with negative and positive cases?
Yes, that's correct. So that would go under your COVID-19 results reporting, either to the patient or to public health. Please report that based on your practice. So if you call patients with negative results, include that. If you do not call patients with negative results, don't include that in your volumes. So base it on your own activity.
Next question, public health hosts the call center and does not call backs. Public health hosts the call center and does the callbacks, not our assessment center. Do we still include this information?
So if your assessment center does not do it, do not include it. You can include a note that will help us understand that it is because you don't do it, not because you've forgotten to fill it out.
Can I ask people to put themselves on mute if they're not Judas, essentially? Sorry. Type all of your questions in the chat box. That will ensure that we can hear the answers. Next question: do we include hospital lab costs related to relabeling swab tubes to go to the lab for reprocessing?
I would say no. Based on what I said at the beginning of this presentation, lab costs have been collected already through a separate template, and that we have asked the labs to include the cost of sample sorting, sample packaging, sample accessioning, anything that they are doing at the lab. We have asked them to submit to us through the lab template, so do not include that here.
We haven't been collecting this kind of detailed information throughout. It would have been helpful to know this was going to be a requirement. I guess we'll just estimate. Okay, Judith, you can take that one.
Yes, please estimate. We recognize that in some cases, it will be more difficult to estimate than others. You think about an average or a typical patient when you're trying to do the estimates. Also think about your total number of hours per day that are worked and compare that to how your activity time adds up. So you can sort of double check your estimate by saying, okay, I'm estimating that it's 5 minutes per patient. multiplied by 50 patients per day. That gives me a total of this many minutes. Does that sound like the actual time I spend per day? And you may need to consult with your colleagues, if you're not directly involved as the person filling out the template in all of these activities.
So I just wanted to make it clear, this is not exactly a requirement. It is what we're trying to get here is as accurate information about your cost structure and cost drivers and reasons for cost variation. It's not that we're like requiring you to provide this information, but it is vital for us to be able to understand what the cost drivers are, to be able to do something useful with that information. We really appreciate your time and efforts on that. It's not something like you would have in a schedule in your agreement. That's not that type of requirement. And we also tried to incorporate the lines where we would appreciate that detailed information. However, if you are unable to provide it as the aggregate level as total cost for supply groups of items. So we try to consider that. So the next comment is again about in the same direction. I'm struggling why we need to provide this level of detail. How will this information be used? So again, this is for us to better understand what drives the cost in your facility or in your model of care. And without that level of detail, we'll just have a bunch of numbers, but we won't be able to have any explanatory factors why they're different. So it will be very hard for us to make sense of the variations. If you absolutely cannot provide that level of detail and you feel that it's not we don't have the option for you to accommodate giving us the information in the form that we've provided it for, then provide it to us as a separate file at the most total level aggregation. And the only risk of it, depending on how we can, when we receive all the information, how we can incorporate it, that we may or may not be fully able to accommodate this information in the analysis. Judith, did I say, do you want to add anything? Because there are quite a few questions. Do you want to add anything to these ones?
No, I think that covers it.
Okay, great. So yes, so I'm just getting some comments here as well, that we do know that there is a significant variation, and without the level of details, again, we won't be able to explain why, or so that's the premise, right? Then next level is next question is, test results come back to our assessment centers in batches, but reviewing the results and reconciling them into the charts and annotating on them is done on individual chart basis. How do we incorporate that estimate?
So I would say that even if you are doing that work on a per chart basis, we would ask that you roll it all up into your COVID-19 results reporting to public health. Or if you've covered it under your admin and support staff, if some of this is clerical data entry IT work, it can be incorporated into your hours. If you have a person working full time to do that, then that can be covered there. In order to convert a per chart cost into a total, you would just multiply the minutes it takes you per case by the number of cases you would do in a day and report it as a total here.
Thank you. Next question. We've changed our model literally this week. The report will be different from March 16 to July 6 than what it is this week. Should we report the previous data? That's a very good question.
Say,
it was sort of, yeah.
Yeah, I would say that if you have already changed your model, we would like to know your current state, which is your changed state. The challenge is that you may not have enough experience yet with that new state to accurately estimate things like time. So use your best judgment. We would like your most current state, so we would prefer basically your refreshed model. But if you feel like you can't accurately estimate the time required under the new model, then use the time that you can most accurately estimate, which may be the old model.
Thank you. If we have 3 sites, do we consolidate into one report or submit 3 separate reports?
Okay, that's a really good question. And we received that question via email as well. So I would say there are 2 options. So if, for example, turning to the in-center tab, say you have 2 in-center assessment centers in 2 different locations. Your 2 options are, number 1, if the centers are relatively similar in terms of their the information you would report. If, for example, the time for patient registration, the time for swab collection, your security hours, etc., your additional activities and your supplies are similar between the 2 sites. You know, if you have similar cost structures, similar estimates, you can aggregate them together under one. And in the case of aggregating them together under one, you would report the total volumes across both sites, total hours across both sites, the total FTEs and hours across both sites, and then you would report the average of all of these activities across both sites. So assuming that you know, if one site takes 5 minutes and the other site takes 7 minutes, your average would be 6. If only one site offers additional services, that's fine, because you could just report the volume for that site. You would also report your total supplies, so you would report all your units of supplies across both sites and all your overhead across both sites. Option 2, if your 2 sites are very different, meaning that the time required for all of these activities is different between the 2 sites, the services are different between the 2 sites, maybe the costs for supplies, etc., are different between the 2 sites, please give us 2 separate templates. And when you email us the 2 separate templates, in your email, note that you've provided 2 templates in order to capture different cost structures across 2 different assessment center sites, or you know, any of the models. If you have multiple mobile teams that have different cost structures, you can submit 2 templates. That's an option for you if your sites are so different that it doesn't make sense to aggregate them together. It will be less work for you, I think, if they're similar enough that you can aggregate them together. So I would encourage you to do that. But if that is not feasible for you, we will take 2 separate templates, or three, or 4, if that's what's required.
So next question is, consideration should be taken for centers who have switched model since the beginning and might even have to switch model, such as drive-through model may not be preferable in winter. So I think we already addressed this question. Please, if at all possible, capture what your current operational model is. We're fully aware that as fall and winter come along, there may be changes. There may be changes in a lot of things. So we are capturing what's currently happening, not what will happen in the fall or happened 2 weeks ago, if there was a change since then. So next question is the documentation related to symptomatic and asymptomatic people is in a paper chart format. We would not be able to generate the data unless we went through each chart. So it's about potentially proportion of symptomatic and asymptomatic. I will, Judith, do you want to take this one?
Please,
like essentially.
yeah, please estimate. We don't expect you to go to do time and motion studies. We don't expect you to do precise data collection. Estimate. So you may not know the exact number of symptomatic versus asymptomatic, but I hope that you would have a sense of whether it is 5%, 10%, 20%, 50%.
Yes, just to emphasize the point, we do appreciate that this is a very time-consuming exercise. We really do. It's you know, we felt on our end when we set up this template what it actually means. So we're with you on that. We are not looking for precision here. We're looking for your best estimate without you having to spend a lot of time trying to figure out what the numbers are. Use your best judgment. Don't spend too much time on each number, if at all possible, to provide just an educated guess. Next one, it looks as if you can only enter one staff type. For example, for symptomatic patients, patient education and counseling, we have students, nurses, NPs, and physicians providing this information. You can only enter one personnel type. How do you enter more? That's a great question.
So a lot of these questions are actually covered in the instructions. So in this case, the instructions say where multiple personnel types are used in the same process step, please use the most commonly responsible staff person. An average salary per hour, which would reflect the mix that you use, and note the other staff types in the notes. So if it is usually a nurse, you would put nurse. You would note that it is sometimes this list of other staff types. You can give us the percentages as well for additional precision. It is not mandatory. And then you would adjust your average hourly rate to reflect that staff mix.
Next one, if a sample transportation isn't provided by assessment center, we'll leave it out?
Correct. Anything that you do not do, you can leave blank.
Next question, regarding lab costs being excluded, are you referring to the lab who actually processes the tests? What about the hospital lab costs? Our lab does not process swabs incurred in preparing requisitions, packaging for transport, resulting, etc. Should we roll this cost in?
So the lab template includes lab costs for labs that are rerouting samples. That template collected costs on rerouting activities that are done by the lab, including accessioning, packaging, send out, and results entry into your lab information system. So that is all covered in that template.
If public health is the one hosting assessment center, do we need to complete this costing template, or is it the hospital it's affiliated with?
I'm not sure I understand that question. If whoever is hosting the assessment center and is responsible for the assessment center and understands the operations of the assessment center should be submitting the template.
So Yasmin, can I ask you to help here on this one? So the question is again, if public health is the one hosting assessment center, do we need to complete this costing template, or is it the hospital it's affiliated with?
I think I'm having the same problem as Judith, where I'm not quite sure I understand. I think I would suggest whoever, like if there is a hospital affiliated with the assessment center, that hospital should complete it to the best of their ability, and note where appropriate that the public health unit is contributing to costs.
So next question, and whoever has the other question, if you didn't give the satisfactory answer, please just send us a comment and maybe provide more information for us to follow if you didn't get the answer that would be helpful to you. Next question. Can you please be a little more specific as how this information will be used? Also, is this only a one-time reporting requirement, or would you require regular updates? So as Vicky pointed out at the very beginning, what this information is collected for is for us to be able to understand the cost variation and cost drivers among different types of providers or model of care. And we will be analyzing that and putting it forward as inputs into more strategic questions. Vicky, do you want to add to that?
Yeah, no, I think Julia, you touched on it, but I guess what I'll say is right now there are questions that are continually coming up around what does it cost to conduct assessment and specimen collection, and what do those costs look like depending on the model? And right now there isn't an answer to that question. And so the purpose of this exercise is to be able to provide those answers when they're asked, which then will inform future planning. The other piece that I'll speak to, because I think kind of a related question, is why the timeline is what it is. And I do just want to note that part of why we set the deadline where we did is really in the hopes of being able to use this information to also inform the government during times of budgeting. So that's kind of the other piece in terms of the purpose, is being able to use this as is information into future planning from a government perspective. And also, I am not aware of any plans to make this requirement, reporting requirement, regular. Vicky, can you please comment on that? Yes, absolutely. Thank you, Julia. Yeah, we have conceptualized this as a one-time exercise to answer specific questions that are in place right now. If it was found that there would be a need to do this again in the future, then we would work with you on that. But certainly that need at this point has not been identified. So we do see this as a one-time item. Thank you. And then the last question that right now I haven't. Yeah, sorry.
So no, if it's the last one, then go ahead.
We did a one-time drive-through pop-up last week with significant volumes and staffing costs. Do we include? I would say yes if this is your model. Judith, do you want to add to that?
Yes, I agree. If this is your model and you intend to continue to offer this pop-up, please include it. If it is truly one time and will not happen again, then I don't think there's a purpose in including it. But if it's going to be an ongoing model, please do include it. Okay, so if that's all the questions, I'm going to keep going. I think we've touched on the future tabs already for some of in answering some of these questions. So hopefully I can move through these quite quickly and get us done in time. So for if I could speak about, so both in-center and drive-through are similar in terms of the information collected. Again, we're looking for information on your basic operations. So the location of your site or sites, list all of them if there are multiple locations, your operating hours and days, your typical volumes, your staffing, your testing activities, and these are again broken down by all the steps. We've tried to group the steps into the categories that we think will be most common to all centers. Recognizing these may not match your model exactly, try to fit your activities as best you can into this list. And there is a row for others specified. We've included activities per case. So in these cases, you would estimate the number of minutes required for each person coming through the testing center, and then also activities like security, navigation, where you probably just have a staff person who has to be present at the center during its hours of operation. So you would just give us the total minutes per day in that case. If you offer additional services associated with your assessment center, they can be noted in the table below. If you do not offer additional services, just leave that blank. I'm going to talk a little bit about supplies. So supplies can either be provided in an itemized format, and we've included some general categories based on what we heard from our interviews. So swabs, PPE, and a few other categories. You can also optionally provide your supplies as a total cost, not itemized. Recognizing that will make your information less comparable to other sites, but that is an option that is available to you. Optionally, you can give us additional information about the supply and then just units per day, cost per unit, and it will calculate a cost per day for you. Similarly, overhead, we have general categories suggested here based on our interviews for what you may have in your overhead costs. Fill in your cost units, which in this case is per day, per week, or per month, cost per unit, and the percent associated with COVID testing. So that may be 100%, that may be 20%, whatever it is, and then it will calculate your cost per day for you. I'm not going to spend too much time on drive-through. It's very similar to the format of the in-center testing. We assume with the drive-through that it will be a simpler model and it will not include additional services. So we're assuming that the drive-through may reroute patients elsewhere for follow-up. So that's included here, but otherwise the template for drive-through is the same as in-center. One thing I want to note is if your particular model is that you operate in-center 5 days a week and drive-through 2 days a week, that's totally fine. Just make sure that you change your operating days to 5 for in-center and 2 for the drive-through, so that we know that that's your operating pattern. Mobile teams. So mobile teams are a little bit different from in-center or drive-through. Instead of estimating the total cost per day for the mobile team, we're looking for the total cost per visit and the number of site visits by your mobile team per week. So your volume will be a function of your number of people seen per visit times your number of visits per week. And then the costs below are going to be estimated per visit, and then we'll multiply those by your average visits per week. Once again, we want to know what your staffing is for each visit, your activities that are done per visit, and similarly to the other tabs, these are structured in terms of activities that are estimated in terms of time per case, as well as activities that are independent of the number of cases. So that would be, in the case of the mobile team, things like your setup and your takedown, any pre or post coordination or support that you're providing. Similarly, supplies are included here, and the format is the same as on the other tabs in terms of how the data collection works. And then for mobile teams, we're also collecting transportation costs, getting your mobile team to and from the site. So the unit is per visit, like everything else on this tab, round trip. You can give the cost to us itemized, or you're very welcome to provide total transportation costs not itemized. I know there's a lot of variation in how teams are doing their transportation. We're also collecting optionally, if you can provide this to us, your average distance traveled. This will help us to understand the variation between assessment centers in this cost based on the distance traveled. Okay. Home visit is very similar to the mobile team in terms of the data we're collecting. I would point out that we are still asking for average volume per visit. I recognize that this may well be 1, but we didn't want to assume that it would always be 1. So go ahead and enter average volume of 1 per visit if that's the case. If it's not, enter what your average number is. And again, visits per week, and a similar data collection in terms of the activities, the supplies, and the transportation cost. Specimen transport may or may not apply to your assessment center because we know that the labs are picking up the transportation costs in some cases. So if your lab your labs are covering transport, don't report it here because it's already reported under the lab cost. So let us know which it is. If it's sometimes, tell us the percentage. Fill out as much of this as you can because transportation costs can vary based on your volume as well as your geography. So we're looking for information on your samples transported, the number of trips that you have to do, and the total distance traveled, which will give us different views onto your cost structure and how it may compare or differ to other sites. Similarly to the mobile team transportation costs, you can give us either itemized costs if you have them, or you can give us total transportation costs not itemized. And this can be reported to us either per day, per week, or per month, however you normally would be billed for that. And it will calculate it as a cost per day based on the units that you've entered. Okay, finally, well, not quite finally, but almost finally, the summary tab is for your information and for our information. There's no additional data entry here, but this will allow you to see how all the data that you've entered on the previous tabs is rolling up into a few different cost metrics. So it will collect your total number of initial assessments, your swabs completed, and your total average symptomatic cases. So those are your overall volumes across all your different models, plus your admin cost. It's going to give the total FTEs across all your different models. Check this cell and make sure that your FTEs are not being double counted. Similarly, check and make sure your FTE costs are not being double counted because it does sum it up across all your different models. It also gives a comparison for your labor costs based on all activities. So your an example is that your FTE cost is added up here based on your total number of hours. Your labor cost is based on your activities. So that's a roll up of what you've reported in the steps and is totaled here. We don't necessarily expect these numbers to match because you may have some idle time, you may have some other time that your staff are spending on things that are not enumerated in your activities list. However, if they're very, very different, double check your estimates. It also gives you your total supplies, your team transportation, and your overhead cost. Again, calculated per model and for everything rolled up. This tab is tricky to interpret because the total cost is per week, whereas the other costs are either per day or per visit. So recognize that your per week cost is going to be significantly higher because it's multiplying each of your, for example, your per day cost is going to be multiplied by 7 days a week if you operate 7 days a week. Your site visit cost will be multiplied by however many site visits you do. So all of these things are going to be summed and multiplied to give you your total costs. We're also trying to estimate some breakdowns in testing activities in asymptomatic versus symptomatic patients, which is why we asked for those activities separately. The costs associated with your additional services, if you have any, and also including your labor costs independent of the number of cases. All of these indicators will be used for us to understand differences in cost structures based on patient type and based on the number of services that are offered. And then at the bottom, we have your transportation costs. I appreciate we're running out of time, so really quickly, I think we've already covered the other cost tab. This is for your costs that are covered by other entities to make us aware of what they are, if you know what they are. Your future costs, this is optional. If you anticipate changes in your model and you want us to be aware of future cost changes, please put them here. Finally, we are collecting some information on your test requisition and your information system on behalf of some of our colleagues. So we're looking for information on whether you're using the provincial requisition and whether the order is being placed in your information system, which information system, and whether you are interfaced with the performing lab. This is some general information that's going to help us better understand the context in which the system is operating. I think we are out of time.
We have two questions. One of them I will take on, and the other one is hopefully it will be very quick to address. The question we received was, where should we report lost rental revenue on the template? Our assessment center is out of a building we own that we did receive rental income prior to converting to assessment center. Unfortunately, these types of costs will be out of scope. They are opportunity costs. They are not directly, like we appreciate that it's overall impact of pandemic, but for this specific reporting, these costs would be out of scope. And the last question that we've received is, our long-term care mobile team have been on demand and not weekly. How would you want that calculated per week?
If there's a lot of variation, if you're in your mobile team week to week, take the last month, say the last 4 weeks, and average out the number of visits per week over the last 4 weeks. If it's less than one, that's fine. So if you have an average of 1 visit every 2 weeks, then 0.5 would be your average per week.
All right, so I think we're at time. Thank you so much for attending. We are going to pause this session somewhere. We will communicate that after the session, and we will have another session just like that tomorrow. Yes, thank you so very much for your time and for a very good set of questions, and most of all for taking the time to complete the template. We really do appreciate all of your efforts and time.
Yes, thanks so much, everyone. And the content at the next webinar will be the same, but you are welcome to attend it as well if you like.